Welcome to the first lecture in a series of talks discussing physical injury. In part one, we will discuss the basic concepts of fractures, dislocations, and other similar pathologies. In the next approximately 50 minutes, we will discuss the basic concepts of fractures in detail. You will see multiple examples of fracture types, learn about diagnostic techniques, become familiar with stress and insufficiency fractures, and learn about osteochondritis dissecans. This lecture is part of a comprehensive series covering basic diseases of the musculoskeletal system. The information for this lecture and following lectures of this extensive series is taken directly from the fourth edition of Bone and Joint Imaging by Resnick and his group, which was recently published in early 2024. I have sole permission of the author to build these lectures. So let's get started. Please note that throughout this lecture series, you will see slides which discuss key concepts. These concepts are what we will discover throughout the lecture. You should pay particular attention to the information on these slides, as well as the examples of radiographic pathology that you see. Trauma results in significant changes to bones, joints, and soft tissues. These alterations often manifest as fractures, dislocations, and tears in muscles and ligaments. Trauma can impact the growth plate of the developing skeletal and modify joint structures. It is also a known precursor to complications such as pain syndromes, bone diseases, and infections. In addition to mechanical trauma, the musculoskeletal system can sustain non-mechanical injuries from thermal and electrical sources, radiation exposure, and certain chemicals. Specific types of fractures and skeletal abnormalities are prevalent in case of child abuse. More often, trauma can influence the development of certain neoplasms, including aneurysmal bone cysts. Overall, the effect of thermal and electric injuries, irradiation, and chemical exposure are significant contributors to non-mechanical trauma within the musculoskeletal system. Conventional radiography is the primary and most effective method for routinely assessing skeletal injuries, although we will look at some examples of magnetic resonance imaging and nuclear medicine imaging. When it comes to uncovering ligamentous injuries, stress radiography proves to be a powerful tool. This technique, which involves manual stress, gravity stress, or weight bearing, is invaluable in diagnosing these hidden injuries. Stress radiography is frequently employed for injuries to the acromioclavicular joint, injuries to the knee, ankle, and foot. It is particularly adept at evaluating Salter-Harris type 1 growth plate injuries, as well as assessing Bowler's fractures and elbow injuries. A prime example is depicted in the image, which illustrates manual stress applied to the ankle joint. The anterior-posterior radiograph taken during varus stress of the plantar flexed foot clearly shows varus tilt of the talus in relationship to the tibia, along with widening of the superlateral mortise. These signs unmistakably indicate an injury to the calcaneofibular ligament. CT imaging is an excellent modality for identifying the presence and extent of fractures or dislocations, as well as for detecting intra-articular effusions and osteochondral fragments. While CT can assess soft tissues following trauma, magnetic resonance imaging and ultrasound generally provide more accurate evaluations of these soft tissue injuries. CT is most frequently used to examine regions with complex anatomy, such as the spine, face, pelvis, glenohumeral joint, midfoot, and hindfoot. It is also valuable in cases of intra-articular fractures to evaluate joint alignment. Consider this complex fracture dislocation of the left hip. The initial radiograph on the left reveals a displaced fracture dislocation of the right femoral head and neck, with a portion of the femoral head extruding peripherally indicated by the arrow. The 3D reformatted CT image on the right, viewed from the patient's back, illustrates the abnormal relationship between the displaced femoral head, shown by the arrow, and the femoral neck and the acetabulum. These 3D CT reformatted images are particularly helpful for surgical planning in complex injuries. CT angiography plays a crucial role in the identification and treatment of post-traumatic vascular abnormalities. These abnormalities can be caused by multiple mechanisms, including a tear from the presence of a sharp bone fragment, compression of vessels from a hematoma, or swelling within a tight fascial compartment, or even a shearing injury. It is important to note that the vessels that are injured most often are those closely adjacent to the bone and held rather fixed by fascial or muscular attachments. The left image shows a lateral radiograph of the distal femur showing an open displaced femoral shaft fracture with large amounts of gas in the soft tissue and a greater than full shaft with posterior displacement of the distal fragment. The right image is a three-dimensional CT angiogram of the lower extremities, demonstrates interruption of the left superior femoral artery indicated by the arrow at the level of the osseous injury. Resonance imaging is highly sensitive to injuries involving bone, cartilage, and soft tissues. This sensitivity makes MRI an important supplementary tool for diagnosing injuries in trauma patients, especially when initial radiographs are either negative or inconclusive. MRI is particularly beneficial for evaluating osteochondral injuries and stress fractures. It effectively assesses both acute and chronic soft tissue injuries, leading to its increased application because of its accuracy and sensitivity. Here we see in the left image an occult fracture of the distal radius that was not detected on the initial postero-anterior radiograph. However, it was later identified on the coronal P1-weighted MR image. This fracture, which is located within the joint and is undisplaced, is indicated by the arrows. Additionally, another fracture at the proximal pole of the hamate is marked by an arrowhead. Likelihood, location, and type of fracture resulting from an injury depends on several factors. These factors include the individual's age and sex, the nature and cause of the injury, and any predisposing conditions that may affect the bones or soft tissues of the musculoskeletal system. Everyday situations that can lead to skeletal injuries include birth-related trauma in newborns, sports-related injuries in adolescents and young adults, work-related stresses in mature adults, and everyday activities in the elderly. Fracture is a break in a bone or cartilage, often accompanied by soft tissue injury. A transchondral fracture involves the cartilaginous surface, while a chondral fracture affects only the cartilage. An osteochondral fracture includes both cartilage and the underlying bone. A closed or simple fracture occurs when the skin remains intact, preventing any connection to the outside environment. In contrast, an open fracture disrupts the skin, allowing contrast within the outside. Bone fractures may or may not protrude through the skin. Although closed and open fractures can be clinically distinguished, specific signs of an open fracture may be visible on X-rays. Complete fracture occurs when the entire circumference of a tubular bone or both cortical surfaces of a flat bone are disrupted. In contrast, an incomplete fracture involves a break in the cortex that does not extend entirely through the bone. This means that the bone is not completely broken into two separate pieces. Incomplete fractures primarily happen in the rather elastic bones of children and young adults. They can be classified into several types, including bowing, greenstick, and torus fractures. Enhancing your understanding of fractures involves mastering the descriptive terminology. This can be achieved by using terms that clearly indicate the direction of the fracture line about the shaft of long bones or the cortex of irregular bones. This knowledge will allow you to accurately describe and diagnose fractures. Recognizing the four basic types of linear fractures involving the shaft of a tubular bone is crucial. These types are transverse, oblique, oblique transverse, and spiral. Typically, the greater the applied force and the faster it is applied, the more energy the bone absorbs, leading to a higher severity of comminution. This knowledge can help you approach fractures with caution and mindfulness, ensuring the best possible patient outcomes. A butterfly fragment is a wedge-shaped piece that breaks off from the shaft of a long bone, typically occurring at the point where force is applied. A segmental fracture is defined by the presence of two separate fracture lines that isolate a segment of the tubular bone shaft. This typical type of fracture can lead to significant complications regarding blood supply and the rate of healing. The alignment of a fracture refers to the longitudinal relationship between two bone fragments. When the fragments have not moved relative to each other in any plane, the fracture is in anatomic or near anatomic alignment. It is essential to understand that by convention, the angulation of the distal fragment is described in relation to the proximal one. This angulation can be medial or lateral, dorsal or volar, or specifically in the forearm, radial or ulnar. Varus describes the angulation of the distal fracture fragment toward the midline of the body, while valgus refers to its angulation away from the midline, as seen in this illustration. Conversely, when the fracture angles toward the midline, it is known as varus, as shown in image B. Fracture position refers to how the broken bone fragments line up with normal anatomy. If the fragments are not in their normal position, it is referred to as displacement. Displacement involves how well the pieces of bone fit together and if they have rotated. Complete contact between the bone fragments is referred to as 100% apposition and is considered undisplaced. If the bone surfaces are not touching, the degree of separation can be measured. When the bone surfaces overlap, resulting in shortening, it is referred to as a bayonet deformity. Observe the fracture of the shafts of the tibia and fibula. The distal tibial fragment is displaced posteriorly with the overriding of the tibial fracture fragments. Know that the dorsal fragment arrow invaginates into the region of the syndesmosis with widening between the proximal tibia and fibula, indicating syndesmotic injury. The radiograph should include the joints both proximal and distal to the fracture, as this greatly helps in visualizing any rotational displacement of the fracture. Rotational displacement refers to the rotation of the long axis of the bone, a critical detail that the film can capture effectively. When examining this radiograph of the forearm, it is essential to note the posterior-anterior position of the wrist and the lateral positioning of the elbow. The arrows indicate the fractures of the radius and ulnar shafts. The varying diameters at the ends of the radial fracture reflect the degree of rotation that has occurred. An avulsion fracture occurs when a small piece of bone is pulled away from the main bone by a tendon or ligament. In this case, the biceps femoris tendon and fibular collateral ligament are attached to a large fracture fragment indicated by the arrow that has been avulsed at the fibular head. Additionally, there is noticeable soft tissue swelling. An impacted fracture arises when one bone fragment is driven into another. In this example, on the right, there is a sclerotic line shown by the arrows that extends across the lateral aspect of the subcapital region, indicating an impacted fracture with valgus angulation of the shaft in relation to the head. It is important to note the excessive vertical orientation of the femoral head trabeculae, which is associated with the lateral impaction. There are two types of impaction fractures: depression fractures and compression fractures. Depression fractures occur when strong forces impact a weaker bone surface, while compression fractures typically involve the vertebral bodies. After a fracture, the healing process occurs in three distinct phases. The inflammatory phase, which occupies about 10% of the healing time, the reparative phase, which occupies about 40%, and the remodeling phase, which occupies 50% to 70%. Initially, bleeding takes place, leading to the formation of a hematoma, followed by the creation of a clot and a strong inflammatory response. During the reparative phase, the fracture hematoma is organized and fibrovascular tissue forms in that region. This tissue produces collagen fibers and a matrix, creating a provisional or primary callus that stabilizes the ends of the bone. The remodeling phase involves the removal of unnecessary segments of the callus and the growth of trabecular bone along lines of stress. Several factors can influence the healing process of fractures, both locally and systemically. Local fractures include the severity of the injury, the extent of bone loss, the type of bone, the level of immobilization, the presence of infection, and any underlying medical conditions. Systemic factors such as age and metabolic bone disease also significantly affect fracture repair. Imaging plays a crucial role in understanding the successful healing of a fracture. It allows us to witness the gradual disappearance of the fracture line, the formation of callus bridging or buttressing across the fracture, and the restoration of cortical and marrow continuity, providing us with a comprehensive view of the healing process. Sometimes the healing process is delayed, called delayed union, or stops altogether, referred to as non-union. Non-union is a term used when a fracture site has not fully healed within a specific time. This is usually defined by 9 to 12 months after the injury and not sooner. It is important to note that movement at the non-union site can lead to the formation of a synovium-like cavity and synovial fluid or fibrocartilaginous union. Non-union of fractures in the clavicle, scaphoid, humerus, ulna, tibia, and femur is most commonly encountered. Healing issues can be divided into delayed union and non-union on one hand and malunion on the other. Malunion describes a fracture that has healed in an improper position, such as extensive angular or rotational deformity. It is important to remember that in children, malunion may resolve as further skeletal growth and remodeling occur, offering a potential for resolution and reassurance. Here we present two examples of abnormal fracture healing. The image on the left demonstrates a classic hypertrophic non-union at the ulnar shaft fracture, indicated by the arrow, characterized by a prominent external callus and enlarged irregular bone ends. In the image on the right, a different patient with proximal humeral non-union, indicated by the arrows, shows the atrophic form of non-union with minimal callus at the fracture site. Pathologic fracture occurs when a bone breaks at a site where there is already an existing problem, typically due to a force that would not ordinarily cause a healthy bone to break. Any condition that weakens a specific area of the bone can lead to a pathologic fracture, the most common cause being a bone tumor. When examining an X-ray, it is generally easy to determine whether a fracture is pathologic. Indicators include a large area of damage to the broken bone, visible erosion of the outer layer of the bone, or the presence or abnormal areas in nearby or distant bones. For instance, an oblique fracture line, indicated by the arrows, through a primary Langerhans cell sarcoma can be observed in the distal portion of the femur. This image illustrates mixed osteolysis and osteosclerosis associated with the underlying tumor, as well as cortical irregularity and periostitis, noted by the arrowhead, related to this rare neoplasm. When a small lesion is present, it can be difficult to see because the fracture can obscure it, especially if the bone is not correctly aligned. If a pathologic fracture is suspected, CT scanning and MR imaging can be used to check for an underlying lesion. Diagnosing a non-pathologic fracture, a task that requires continuous learning and improvement, can be challenging because it may appear to have an underlying lesion due to bone changes around the fracture site. Here we have an example of pseudopathologic fracture. In the image A, an anteroposterior radiograph of the left hip, we see a femoral neck fracture with an apparent region of osteolysis indicated by the arrows at the superior neck. In image B, the axial CT scan provides a more detailed view, showing that the defect is related to an angulation at the fracture site, creating a gap which is indicated by the asterisk between the fracture fragments at the anterosuperior femoral neck. Stress fractures, which can be prevented with the right knowledge and precautions, occur when a normal or abnormal bone is subjected to repetitive loading, resulting in micro damage that is not adequately repaired. This occurs when the bone is subjected to repeated forces that exceed its ability to adapt and to repair. It is important to understand that there are two distinct types of stress fractures. Fatigue fractures, which result from repetitive stress on a bone that is normal, and insufficiency fractures, which occur when everyday stress is applied on a bone that is deficient, as in osteoporosis. These fractures are not uncommon among athletes and military recruits, especially in runners and in ballet dancers. Examples include march fractures in military recruits' metatarsal bones and lower extremity fractures in athletes, joggers, and dancers. Insufficiency fractures can arise from various factors, including osteoporosis, rheumatoid arthritis, Paget's disease, and others, as seen in the list. It's important to note that bisphosphonates, which are commonly used in the treatment of osteoporosis, can also cause a specific type of insufficiency fracture in the lateral femoral cortex when the patient has used this medication a long time. In this case, we present an insufficiency fracture that occurred after bisphosphonate use. The radiograph shows an incomplete transverse fracture of the lateral femoral cortex indicated by the arrow, a crucial finding linked to the prolonged use of bisphosphonate therapy for osteoporosis. This highlights the importance of recognizing radiographic features in diagnosing insufficiency fractures. Additionally, observe the multiple regions of undulating and beak-like bone proliferation along the lateral femoral cortex below the fracture site. Stress fractures, often identified by localized tenderness and soft tissue swelling, are characterized by activity-related pain that is effectively alleviated by rest, underscoring the crucial role of rest in the treatment process. It's important to note that more than one site can be affected simultaneously, allowing for the occurrence of multiple stress fractures in a single bone, which can lead to symmetrical changes. The X-ray abnormalities depend on the location of the fracture and the time between the injury and the X-ray. In the shaft of the bone, a thin radiolucent area in the cortex is often associated with thickening of the outer and inner layers of the cortex. Here we see radiographic abnormalities in the diaphysis. Note that the irregular radiolucent areas arrow in the anterior cortex of the midshaft of the tibia. Cortical thickening and periosteal new bone formation about these incomplete fractures are evident. Sometimes we can see multiple radiodense lines that extend wholly or partway across the outer layer of the bone. When this occurs, we typically find sclerosing of the trabeculae. It's important to note that we rarely see swelling of the periosteum of the bone, which can provide reassurance in our diagnosis. As the bone heals, the sclerosis may spread, and eventually both the sclerosis and the line where the bone fractured may disappear. In this image, we see band-like focal sclerosis demonstrated by the arrows that is typical of a stress fracture of the proximal portion of the tibia. Using radionuclide bone scans can help detect bone stress injuries early. In athletes, unusual scintigraphic patterns may indicate increased stress before a fracture develops, such as in cases of shin splints. Shin splints are disruptions in the tissue covering the bone, possibly caused by the breaks in Sharpie fibers as they tear away from the bone. In patients with shin splints, we typically observe poorly defined areas with slightly increased radioactive material along a long stretch of tibia. This pattern differs from what is usually seen in acute stress fractures, where there is a smaller, more focused area of increased activity. Stress fractures are generally longitudinally oriented, resulting in long areas of intense activity, most frequently located in the tibia. Scintigraphy of stress fractures is indicated in image A. Images of the lower legs taken during the delayed portion of a bone scan show intense longitudinally oriented tracer accumulation at the distal tibia. The anteroposterior radiograph seen in image B demonstrates a long intramedullary band of sclerosis exiting the medial tibial cortex, which is related to a longitudinal insufficiency fracture of the tibia. Note the periostitis present at the medial cortex of the fracture. Fractures in the calcaneus, often associated with osteoporosis, rheumatoid arthritis, neurologic disorders, and other diseases, underscore the importance of early detection and proactive management. It is important to note that while fatigue fractures in the calcaneus are less common, they do occur, particularly among military recruits. Stress fractures in the tarsal navicular bone are a common occurrence in physically active individuals, such as basketball players and runners, underscoring the need for caution and awareness. The left image demonstrates a tarsal navicular stress fracture. The AP radiograph of the foot shows a sagittally oriented stress fracture in the tarsal navicular bone. There is sclerosis at the lateral pole, suggesting ischemia or early avascular necrosis. A calcaneal stress fracture is seen in the right image. Note the vertically oriented sclerotic line at the calcaneal tuberosity. The fracture line courses perpendicular to the weight-bearing trabeculae, typical of an insufficiency fracture. Now we will look at specific fractures and their appearances. Stress fractures of the proximal diaphysis of the tibia can occur during running. Stress fractures of the middle and distal tibial diaphysis can occur during specific activities such as running, marching, and ballet dancing. The posteromedial portion of the tibial cortex is affected more frequently than the anterolateral portion. Shin splints, a condition related to multifocal stress injury along the anterior tibial cortex, result in a pain that is milder and more diffuse than that of a stress fracture. Observe a transverse fracture of the posterior tibia at the proximal metadiaphysis in an avid runner. There is sclerosis surrounding the fracture along with inflammation of the periosteum, a condition known as periostitis. There are two types of fractures in the femoral neck, with one being more common in the younger patients and the other in older patients. Additionally, fractures in the femoral head can be observed in osteoporotic patients and during pregnancy, making it hard to tell them apart from osteonecrosis. Here we present a coronal T1 weighted image labeled A and a fluid sensitive image, MR image of the pelvis labeled B. These images identify a fatigue fracture in the medial portion of the left femoral neck with a short fracture line on the compressive side of the bone, surrounded by marrow edema. Stress fractures commonly occur in the metatarsal bones due to activities such as marching, ballet dancing, and prolonged standing. Foot deformities and the surgical removal of nearby metatarsal bones can also lead to these fractures. The most frequently affected areas are the middle and distal regions of the second and third metatarsal bones, although any metatarsal bone can be involved. Fractures of the first and fifth metatarsals typically occur at the base of the bone. Stress fractures can also affect the metatarsal heads, resulting in thickening and flattening of the bone just below the joint surface, a condition similar to Freiberg infraction. In Figure A, you can observe patchy bone sclerosis and periostitis at the neck of the second metatarsal, which is consistent with a fatigue-type stress fracture. Figure B represents a long-axis T1 weighted MR image showing a stress fracture that transverses the full width of the shaft, accompanied by irregular cortical thickening related to periosteal new bone formation. The corresponding fluid-sensitive MR image in Figure C reveals an increased signal in both the bone and surrounding soft tissue. Stress fractures of the pubic arch and parasymphyseal bone are commonly found in pregnant women, joggers, long-distance runners, and marathoners. Similar fractures can also occur in patients with hip osteoarthritis, individuals who have undergone hip replacement surgery, and those with traumatic or iatrogenic instability of the sacroiliac joint. Additionally, these fractures may arise after radiation treatment and are often associated with conditions like osteoporosis and rheumatoid arthritis. In this case, we see multiple stress fractures in the pelvis of a middle-aged female runner who has osteoporosis, disordered eating, and amenorrhea, a condition associated with the female athlete triad. There is an acute fracture at the junction of the superior pubic ramus and acetabulum, along with disruption of the medial acetabular wall and protrusio deformity. A healed insufficiency fracture is present at the inferior pubic ramus marked with an orange asterisk. This patient has previously undergone cephalomedullary femoral fixation for an earlier fracture at the lesser trochanter and medial femoral neck. Insufficiency fractures of the sacrum are a type of stress fracture that occur when normal stress is applied to bone that has reduced elasticity or stress. This typically happens in individuals with underlying metabolic bone diseases, with osteoporosis being the most common cause. Key risk factors for this type of stressed fractures include osteoporosis, by far the most common cause, leading to weakening porous bones. Older adults are more susceptible due to age-related bone weakening. Females, and particularly elderly women, are particularly at risk. Radiation can damage bone and increase bone fragility. Steroids can lead to bone loss, and rheumatoid arthritis can affect bone health. Other metabolic bone diseases like Paget's disease, renal osteodystrophy, and hyperparathyroidism can be underlying causes as well. In young skeletons, fractures that do not fully break through the entire bone are common. Incomplete fractures can also occur in adults, particularly in thinner bones, but they are less common than in young children. A green stick fracture happens when a bone breaks on one side but does not separate. Instead, it disrupts the inner structure of the bone. The term green stick fracture is derived from its resemblance to a young tree branch that has been bent but not entirely broken. This type of fracture shows disruption on the outer surface of the bone while remaining intact on the inner surface. Green stick fractures typically occur in the proximal metaphysis or diaphysis of the tibia, as well as in the middle third of the radius and ulna. Note that in the fracture which is indicated by an arrow, only one side of the fibula is affected, and the break does not extend completely through the bone. Porous fractures commonly occur in the metaphyseal regions of the long bones. On X-rays, these fractures may appear normal unless there is subtle bulging of the cortex. When both compression and angular forces are applied, it can result in a combination of green stick and torus fractures, which is referred to as a lead pipe fracture. In the case of a torus fracture, note the buckling of the ulnar-sided cortices of the radius and ulna, while the contralateral cortical surface remains relatively intact. Infants and toddlers can suddenly develop a limp without any obvious history of injury. A classic example is a toddler's fracture, which is a non-displaced oblique fracture of the lower part of the tibial bone. This type of fracture can be challenging to identify on X-rays and may only be discovered through additional imaging or follow-up X-rays that reveal inflammation about the tibia. While this type of fracture is the most common, similar symptoms may also arise from hidden fractures in the fibula, femur, metatarsal bones, especially the first one, and less commonly, the heel bone or calcaneus. Most toddlers' fractures occur in children aged 1 to 3 years old, with some instances occurring before the age of 1. For example, a follow-up radiograph taken of a 2-year-old who is refusing to bear weight shows periostitis along the tibial shaft, which is associated with a non-displaced fracture of the distal tibia. The initial radiograph, which is not displayed, revealed a questionable hairline lucency in the area. We will now discuss a different type of fracture that involves a soft tissue component, acute chondral and osteochondral fractures. When joints move abnormally, this abnormal movement can lead to fractures within the joint surfaces. These fractures can involve only cartilage and are referred to as chondral fractures, or both cartilage and underlying bone, referred to as osteochondral fractures. A fragment that is purely cartilaginous will not show up on X-rays, whereas a fragment containing calcified cartilage and bone will. Additional signs such as soft tissue swelling and joint effusion may be present with early types of fracture. After an injury, the detached portion of the joint can result in various issues. It may remain in place, be slightly displaced, or become loose and free within the joint cavity. Acute chondral and osteochondral fractures are illustrated in the diagrams here. Fragments can consist of cartilage alone, as seen in diagram A, or both cartilage and bone, as seen in diagram B. Chondral or osteochondral fragments can remain in their original position, be displaced within the articular cavity, as shown in diagram C, or become embedded in a distant synovial site, as seen in D, potentially causing a local inflammatory reaction. To find loose osteocartilaginous bodies in the joint requires a thorough search of the joint's recesses. These osteochondral bodies are commonly found in certain areas of the elbow, glenohumeral joint, hip, and knee. Finding these bodies should prompt a search for where they came from. Osteochondral injuries often occur alongside joint dislocations. For example, the glenoid region of the scapula and humeral head can be injured during a dislocation of the glenohumeral joint, and the patella and lateral femoral condyle can be injured during a patellar dislocation. Acute osteochondral fracture in the lateral patellar dislocation. On axial CT image on the left, note the osteochondral fracture with missing bone, indicated by the arrow at the median ridge of the patella, and how shallow the trochlea is. The right image is a sagittal reformatted CT image, which shows the displaced osteochondral fragment lying within the intracondylar notch. Note the large knee effusion within the joint. Osteochondritis dissecans most commonly occurs on the inner, non-weight-bearing surfaces of the medial femoral condyle, on the patella, and on the talar dome. The bone fragment can be stable, unstable in situ, or displaced. If there is fluid separating the osteochondritis dissecans fragment from the parent bone, it suggests instability. An unstable fragment can displace and migrate, leading to the formation of osteochondral bodies in the joint. Osteochondritis dissecans involves breaking and possible separation of part of the joint surface. It can start in childhood, middle age, or most commonly during adolescence. Some people may not have any symptoms, but others may experience pain when moving, limited motion, clicking, locking, and swelling. One or more areas can be affected. This condition is generally believed to be the result of a bone and cartilage fracture caused by certain forces. Determining the stability of the broken bone and cartilage is important, and MR is the most useful imaging technique for this. High signal intensity deep to the bone and cartilage fragment on MR imaging can indicate the presence of unstable tissue, but it's not always a definitive sign. The presence of fluid around the fragment or cysts beneath it are the best indicators of instability. We see a coronal T1 weighted image left and fluid sensitive image right. MR images reveal a lesion involving the inner surface of the medial condyle, indicated by the arrows. The fragment is ossified, and the junction between it and the parent bone demonstrates intermediate signal intensity in the image on the left and high signal intensity in the image on the right. The abnormalities are consistent with granulation tissue or fluid in this junctional area. Signal alterations of the overlying cartilage are noted, although it may not be completely interrupted medially. These findings indicate a loose in situ fragment. When we see absence of high signal intensity zone at the fragment and parent bone interface, then this indicates a stable lesion. Unstable lesions are characterized by 1. The presence of a high signal intensity line at the osseous fragment and adjacent bone interface. 2. Articular fracture indicated by high signal intensity joint fluid passing through subchondral bone plate. 3. Focal osteochondral defects filled with the joint fluid. And 4. The presence of a 5 millimeter or larger fluid-filled cyst deep to the lesions. The most common location for osteochondritis dissecans is the condylar surface of the distal femur, accounting for about 75% of cases. It affects men more than women, usually between the ages of 15 and 20. Changes usually occur on one side more than both sides. It is most often seen on the inner, non-weight-bearing surface of the medial condyle, but can occur in other areas as well. The bony parts of the lesion can be seen on regular X-rays or CT scans, while purely cartilaginous lesions are better visualized with high-resolution MR, especially when there's joint fluid or following arthrography. The main differential diagnosis is with an insufficiency fracture of the femoral condyle, which happens in older individuals with a sudden onset of symptoms and usually involves the weight-bearing portion of the medial femoral condyle, often with underlying meniscal issues. In the image to the right, we see a classic defect of the medial femoral condyle, indicated by the arrows. In this diagram, we see various examples of osteochondritis dissecans of the femoral condyles. A demonstrates a classic location of the medial condyle. B demonstrates an extended classic location in the medial condyle. C is on the inferior central medial condyle, D on the inferior central lateral condyle, and E anteriorly on the anterior condyle. Osteochondritis dissecans of the patella is rare compared to the femoral condyle. The most common site of the lesion is the middle or lower portion of the patella at approximately 30%, while the superior portion is usually not affected. The cause of the lesion relates to trauma. Radiographs can help identify the lesions, which appear as bone defects near the curved joint spaces of the patella. In image A, a sunrise radiograph reveals bone fragmentation at the central patella, indicated by the arrow. In image B, an axial fluid-sensitive MR image shows the bone fragment with adjacent high signal intensity between the fragment and the underlying osseous bed. The articular cartilage of the patella is irregular and thinned at the margins of the bone fragment. The major differential diagnoses are a dorsal defect of the patella and osteochondral fractures related to direct injury or recurrent dislocation. A dorsal defect of the patella, which likely represents an anomaly of ossification in the spectrum of a bipartite or multipartite patella, is associated with a round and lytic defect with well-defined margins in the superolateral aspect of the bone. Remember, this defect occurs in both sexes, may be bilateral, and is typically asymptomatic. It demonstrates intact cartilage on arthrography. Dislocation of the patella is associated with an osteochondral fracture on the medial side of the patella and, less frequently, at the lateral margin of the femoral condyle. A dorsal defect of the patella indicated by the arrows likely represents an anomaly of ossification in the spectrum of a bipartite or multipartite patella. It is associated with a round and lytic defect with well-defined margins in the superolateral aspect of the bone. This defect occurs in both sexes, may be bilateral, and typically asymptomatic. It demonstrates intact cartilage on arthrography. Dislocation of the patella is associated with an osteochondral fracture on the medial side of the patella and, less frequently, at the lateral margin of the femoral condyle. This axial fluid sensitive left and coronal T1 MR image right show the round patellar defect indicated by the arrow affecting the superlateral aspect of the bone with associated depression of the articular cartilage. Osteochondritis dissecans commonly occurs in the talar dome, with the middle third of the lateral talar border and the posterior third of the middle talar border being the most frequently affected areas. These injuries are often seen in patients who have previously injured their ankles, typically in the second to fourth decades of life. Conventional X-rays can usually show the injury site, which may appear as slight irregularities in the joint surface, shallow excavations, and small bone fragments. CT arthrography and MR imaging can provide a more detailed view of the fracture site, assess the condition of the cartilage, and detect any bone or cartilage fragments within the joint. In the image on the left, we see a medial talar dome lesion. Note the lucent lesion of the medial talar dome indicated by the arrows as the osteochondral abnormality on the anteroposterior radiograph. The corresponding coronal T1 weighted fat suppressed MR image noted on the right shows high signal contrast undermining the displaced fragment indicated by the arrows, indicating the instability of this. Osteochondritis dissecans of the elbow typically affects the capitulum, leading to various radiographic abnormalities. These abnormalities include flattening, cystic and sclerotic changes, and fragmentation of the capitulum. The resulting bone fragments may stay in place or detach partially or completely. Free intra-articular bodies can migrate within the elbow, often getting lodged in the fossa of the distal end of the humerus. Various imaging techniques such as CT scanning, CT arthrography, ultrasound, imaging, and MR arthrography can be used to assess this condition. In terms of the differential diagnosis, it's important to consider Panner disease, which is associated with irregular ossification of the capitellum and typically occurs in younger age groups. Post-traumatic osteochondral fractures, osteochondritis dissecans, and osteonecrosis can be identified at other sites, including other tarsal bones, tibia, humeral head, acetabulum, and glenoid cavity. In the left image, which is an AP radiograph of a Little League pitcher, shows a rounded lucency at the central capitulum. The right corresponding T1 weighted MR image shows the lesion well, indicating it with an asterisk, although the overlying cartilage is not well assessed on this sequence. Of an abnormal force to a bone called loading leads to injury. Factors such as age, sex, and the condition of the surrounding tissues impact the bone's ability to absorb energy. Children's bones are more flexible, leading to different types of fractures compared to adults. Additional factors like previous injuries and surgeries also contribute to fractures. Different types of forces such as tension, compression, torsion, and bending can cause bone injuries. These forces can act independently or in combination, resulting in various types of fractures. Remember, the spiral fracture occurs due to torsion or twisting forces, possibly along with axial compression. This type of fracture is commonly seen in the humerus, femur, and tibia. The fracture lines form an angle of 40 to 45 degrees, showing the direction of the twisting forces. In a spiral fracture, the ends are sharp and pointed with a long vertical segment connecting the fracture lines. If the fracture isn't displaced, there won't be a noticeable gap between the fracture fragments. Another type of fracture is the diaphyseal impaction fracture caused by axial compression and force on bones like the humerus, fibula, femur, and tibia. Here we see a transverse fracture in the long bone. This sagittal CT reformatted image of the lower extremity shows a transverse fracture of the femoral shaft with mild comminution in a patient after a motor vehicle accident. The distal fragment is displayed full shaft width posteriorly, is angulated anteriorly, and shows overriding, causing shortening secondary to muscle contraction. The distal fragment interposed into the posterior musculature and the neurovascular bundle, indicated by the arrows, is displaced posteriorly by the displaced bone. Here we see a short oblique fracture of the midshaft of the ulna, resulting from a direct blow. Spiral fractures result from twisting or rotational forces, perhaps combined with axial compression. They are usually observed in the humerus, femur, and tibia. The fracture lines approximate an angle of 40 to 45 degrees, and the direction of the spiral denotes the direction of the rotational forces. In a spiral fracture, long sharp pointed ends with a long vertical segment connecting the fracture lines are characteristic, and unless the fracture is distracted, no clear space is evident between the fracture fragment. The asterisks indicate soft tissue blisters secondary to the force of the fracture. Here we see an open dislocation indicated by lateral dislocation of the tibiotalar joint in association with a soft tissue defect medially, with the distal tibial protruding through the skin. Note the punctate foci of soft tissue gas indicated by the arrows at the lateral ankle. This is the separation or abnormal widening seen at the symphysis pubis, here indicated by the asterisk, related to pelvic trauma. A midline vertical fracture of the sacrum, indicated by arrows, is also present. On this side, I have listed the topics that were covered in this first lecture. Please review these topics on your own using sites such as Radiopedia and others. This concludes part 1 of Basic Concepts. In the next chapter, Physical Injury Basic Concepts Part 2, we will discuss specific disorders in detail, including fractures of the shafts of long tubular bones and other disorders, and follow that in lecture number 3 with a discussion of dislocations, including terminology with some biomechanics. We will also discuss trauma to synovial joints, symphysis, synchondroses, uncover the Salter-Harris classification of fractures. Then we will touch upon specific injuries with specific names, including slip capital femoral epiphysis, the growth plate injuries about the knee, ankle, shoulder, and elbow. Thank you for attention.